This is CCTA case number 21. The history is that of a 51-year-old man with mild shortness of breath and an abnormal stress test. Let's begin by reviewing the left main. We have 3 phases to review. These can be changed by moving the next or the previous button in the CCTA controls. Let's first start at the left main. It appears to be normal. A very quick way to look at the left main in an orthogonal view is to hit the A button or go to an anterior view. You can see here that the left main appears to be normal. You can change phases just to be confident, but this is normal. Switching back to hitting F on the keyboard or switching to the foot view, we now see that there is clearly some plaque involving the proximal left anterior descending. Let's rotate around that area. This is clearly non-obstructive, although there is some coronary remodeling in the area. Let's see if another phase might just help a little bit to make that sharper. You'll notice that as I pick one of the phases, you can see that there's a bit blurring in this area. This is a classic situation for you to notice that you need to switch to another phase because there is a motion blurring. Switching to another phase and then to the last phase allows this to sharpen up, and you can see again that this proximal segment has eccentric non-obstructive plaque. Continuing down, you can see again eccentric non-obstructive plaque moving down into the mid portion of the vessel, moving down to the remainder of the LAD. This appears to be normal. Perhaps another phase might be more helpful to review this. Still appears to be normal all the way down, focusing all the way down to the apex. Otherwise, this is a normal left anterior descending. So let's switch back to the foot view and use the rapid controls here to get ourselves back up to circumflex. Getting in the middle here, we can begin to see the circumflex vessel come down here. There's clearly some plaque in the first obtuse marginal. We need to investigate that further. The circumflex itself appears to be relatively normal. Let's take a look at the obtuse marginal by rotating around. Again, non-obstructive disease near the ostium. Although further down, there also is likewise non-obstructive disease, although there may be some mixed calcified and non-calcified plaque involving a portion of the OM, but again, non-obstructive disease. Let's look at the right coronary. Moving out, trying to get this into a single view to look at the right coronary artery. You can see again that there is clearly some plaque in the proximal segment. This is non-obstructive. What about near the crux? Rotating around this area again reconfirms that this is non-obstructive. Switching to another phase may or may not help, but this is clearly non-obstructive calcified plaque. Switching to the foot view, we can see the plaque continues down in the distal left anterior descending. There also is an area here of the distal LAD, but again, this is non-obstructive disease, perhaps mixed slightly with calcified and non-calcified plaque. Finally, let's look at the posterior lateral branch here. Appears to be normal, and then we have the posterior descending vessel right here. And this likewise is quite large and normal. So in this 51-year-old man, we have found extensive calcified, sometimes mixed calcified, non-calcified plaque, but it is clearly non-obstructive. And the abnormal stress test is a false positive examination. He doesn't need further testing. He does, however, need to have relatively aggressive risk factor modification, mainly due to the extensive plaque burden.